afternoon. My name is Liz Fogel. I'm the Member Outreach Manager here at LACMA. Welcome to our webinar. It's on who's buying medical practices in California. I'd like to introduce Alexey Nechay, who's going to lead the presentation.
Hi, everyone. My name is Alexey Nechay. I'm the founder and principal valuation analyst at Nechay APPRAISALS, where I help doctors navigate practice transitions. This is going to be our agenda for the day. Before we get to the buyers, we'll set the stage by talking about trends in physician employment and practice ownership. I'll talk a little bit about restriction on corporate practice of medicine in California, and I'll get to the buyers. We'll cover hospitals and health systems, private equity, federally qualified health centers, and physicians and physician groups. I'll give you some background on each buyer and explain how they approach practice acquisition and valuation process. Let's start by talking about physician employment and practice ownership trends. We'll take a look at a couple of graphs. This one shows the percentage of U.S. physicians employed by hospital and corporate entities in the United States between 2019 and 2024. Corporate entities includes private equity, insurers, and any umbrella type corporations that own multiple practices. As you can see, it's a positive trend. January 2019, about 62% of physicians were employed by hospitals or corporate buyers. And now that number stands at about 77, 78% 5 years later. Next slide shows percentage of physician practices owned by hospital and corporate entities. That trend is also positive. It's now about 58, 59% of all practices are owned by either a hospital and health system or a corporate entity of some kind. This information is not really tracked state by state, so we're looking at national figures. If we put these trends side by side, we can see that more and more physicians choose to be employed by hospital or a non-physician practice owner, essentially, and they also looking to sell those practices to not to other physicians. What's interesting is that if we look at the peak of the pandemic, between 2020 and 2022, these trends really accelerated. And it's likely because it was a challenging time for a lot of physicians. The costs went up, employee turnover was very difficult. And I think that a lot of physicians really had to rethink their practice ownership and what they wanted to do going forward. Let's start first by talking about corporate practice of medicine restrictions in California and how that affects buyers. While many states allow hospitals and even sometimes non-licensed individuals to own shares in a medical practice, California has one of the most restrictive corporate practice of medicine laws. The result, corporate practice of medicine laws in California shape how buyers approach acquisitions. The idea behind these laws is to prohibit most corporate entities including hospitals, from directly employing physicians, because that puts at risk maybe as perceived by lawmakers, physician autonomy, and it might influence how they practice medicine. Because of that, all kinds of buyers, they have to get creative in how they structure these deals. There are some exceptions to restrictions on corporate practice of medicine in California. University of California systems, county hospitals, certain nonprofits like community clinics, and some HMOs like Kaiser are exempt. They're exempt from this and can, in fact, employ physicians directly. All right, let's talk about some buyers. We'll start with hospitals and health systems. Hospitals and health systems are now the largest employer of physicians in the United States. They employ about 55% of physicians as of January 2024. And this graph actually goes way back to 2013, where they employed only 27% of physicians. This is the percentage of hospital-owned physician practices. They own about 28%, 29% of all physician practices in the United States. So why do hospitals acquire practices? As healthcare increasingly moves towards ambulatory care, the hospitals buy practices to avoid competition with physician-owned facilities. When hospitals own medical practices, they can effectively coordinate patient care. This often results in patients utilizing hospital-affiliated facilities due to the convenience and integrated medical records. Also, it's a side, I think it's one of the reasons that hospitals might acquire practice is because if the practice is led by respected physicians in the community, that could improve hospitals' reputation in the community as well. As we mentioned earlier, hospitals in California actually can't just hire physicians directly. So they can't really buy practices directly. As a result, they have to get creative. Popular methods that hospitals use to buy practices in California is through hospital-affiliated medical foundations. Medical foundations are nonprofits with a very specific structure that exempts exempts them from corporate practice of medicine restrictions. Most medical foundations, essentially, they act as a middleman between the physician practice, the medical practice, and the hospital. Setting up these foundations is difficult and expensive. To qualify for exemptions, the foundation has to provide medical research and education. I believe they have to have at least 40 physicians across 10 different specialties, with 2/3 of them practicing full-time at the foundation's clinics. As you can imagine, it's very expensive. Not all hospitals can, employ 40 physicians just for the sake of buying practices. So there was a study, I believe in 2018, that said that in California, top 10 hospital and health systems employed about 45% of all physicians. And the number is probably higher today. Let's talk about some of the valuation insights. Hospitals have to comply with Stark Law and anti-kickback statutes, and transactions have to comply with fair market value standard and be commercially reasonable. I included what fair market value standard here for you in case you want to go back to it and read it. But because of these laws, the hospital usually will hire a third party to do an appraisal for them, and it's going to be some kind of consulting firm. And from the standpoint of a physician in a transaction, what I would recommend always is that a physician get their own appraisal, because these firms, although they're supposed to be independent, they might be getting a lot of business from the hospital. It could be tens of thousands, it could be hundreds of thousands of dollars a year for other services as well. In terms of structuring the transaction, most of the time, when a hospital buys a practice, it's going to be an asset sale transaction, not a stock sale. An asset sale transaction means that instead of selling your corporation to someone like a hospital, your corporation is going to sell some of its assets to the buyer. You get to retain your corporation. Transition timeline for hospitals usually pretty long term. From what I've seen, they like to keep the seller, working with them for a number of years. Could be like up to 5 years or longer. And they often offer a pretty competitive salary. So salary does play into the valuation and the value of the practice, because the higher the compensation that the hospital is going to offer you after the sale, that compensation has to be factored in the valuation of the practice. The higher the compensation, the practice will have lower profit, which means the value of the practice is going to go down. So in the end, hospitals might not be able to pay you a lot for your practice, but they will probably be able to justify paying you a higher compensation after the sale. Another notion that I hear a lot from my clients is that hospitals don't pay for goodwill. They do. It's just that they have to be careful about justifying the premium that they pay for the practice in terms of its assets. I've helped a surgeon, I think it was like a year or two ago. He got an appraisal from me, and then he used it to negotiate with the hospital. Ended up getting double what the hospital offered him for his practice. Let's move on to our second buyer, which is private equity. This graph shows % of physicians employed by corporate entities. So this is not just private equity. It also includes health insurers and other corporate entities. But we can see that in 2019, about 15% of physicians were employed by these corporate entities. And it went up through the pandemic, and then it kind of slowed down. So for the last couple of years, that percentage stayed at about 22.5%. Not really sure why. I'm guessing private equity very much relies on the cost of money, right? They're funding themselves through investors. So I think cost of interest rates went up, so investing became a bit more difficult for them. And this is a percentage of physician practices that are owned by corporate entities. So as of January 2024, 30% of physician practices were owned by corporate entities, which is now actually higher than what hospitals own. So hospitals own about 28.5 on the previous slide. Corporate buyers now 30%, surpassing hospitals. So what is private equity? Private equity are investment partnerships that buy and manage companies before selling them. Basically, private equity will pull money from investors, then seek out companies that they can buy, grow, with the goal to later sell them. So the key word here is sell. Some of the interesting facts about private equity in healthcare is that in some local markets, private equity holds majority market share in certain specialties. There's been some studies also that show that following the acquisitions by private equity groups, the cost of services went up in 8 out of 10 practices. Majority of private equity transactions today happen without major government scrutiny. However, this is changing, and I'll touch upon that in a second. This graph right here shows cumulative number of private equity acquisitions of physician practices between 2012 and 2021. This covers 10 different specialties. As you can see, majority of the transactions happened in dermatology, ophthalmology, gastroenterology, and primary care space. I believe these 4 specialties account for about 80% of total transactions during this period. So why do private equity buy practices? They're definitely, they're investors, so they are definitely buying it for financial reasons. I call them the ultimate investor buyer because they're ultimately looking for a return. A physician, hospital might have other goals. Private equities, they invest a certain amount of money and earn a return over, maybe a 5 to 10 year period. Healthcare does offer decent margins, opportunity to make operational investments, improve economies of scale, and that's why they're here more and more. Just like hospitals, private equity have to comply with restrictions for corporate practice of medicine in California. While hospitals might use medical foundations to structure their transactions, private equity will use usually a management services organization. Management services organization is used to split practice operations between clinical and non-clinical. And MSO is usually, because it doesn't employ physicians or provide any medical services, it can be owned by any lay person. You want to be careful here about deal structures. So private equity, again, they're usually pretty sophisticated buyers, so deal structure might not be 100% of a cash up front. It could be, they could give you some equity in an MSO. They might give you some cash, some as an earnout, subject to performance. It gets really, really creative. So it becomes, at some point, it might be difficult to compare apples to apples. Like you might have $1 million practice, but what they're offering you is, a little bit of everything. Here's an example of a structure between a PC, professional corporation, and MSO post-sale. Professional corporation is going to hold insurance contracts and it's going to employ all the clinical staff like physicians, nurse practitioners, physician assistants, etc. Management services organization is going to bill and collect for PC services on behalf of the PC. MSO is going to employ all the non-clinical staff. It's going to own all the tangible assets that are used in practice operations. It's going to be on the lease. It's going to lease the space, and it will perform other administrative tasks. In exchange, a PC will pay an MSO a management fee. It could be a lot of different things. I often see percentage of collections. So, for example, practice might pay 40% of all of its collections to the MSO, just off the top. Currently, there's a debate about negative implications of private equity involvement in healthcare. Many states have issued laws and regulations that limit corporate practice of medicine, specifically targeting private equity acquisitions. Even in California, last year there was a bill moving through the California legislature. I believe it was California AB 3129 that was meant to limit harmful transactions by granting Attorney General approval authority over private equity groups' practice acquisitions. The bill ended up being vetoed by Governor Newsom. These kind of bills, I read about them all the time, popping up in different states. Usually, from what I've seen, they don't really target small practices. So I believe the California bill was applicable to transactions where the practice was grossing like $4 million, which is, not usually a one doctor small private practice, but private equity does like buying bigger practices. If they roll up smaller practices, into one, they probably wouldn't even have to be regulated at all. Let's talk about some valuation insights. As I mentioned before, private equity groups are usually like very sophisticated buyers, right? You're not going to be an uneven playing field. If it's a physician talking about valuing the practice and doing the deal, and you're going to have a private equity on the other side, you might not get the best result because they're so sort of sophisticated. They will probably have their own team that's going to do the due diligence. They will send you a really large list. The due diligence checklist I've seen can be 10, 12 pages long of just bullet points, like just a ton of information from contracts to employee handbooks. Everything you can imagine is going to be on that list. You will need help. You'll definitely need your accountant to help you. It's not going to be, probably not going to be free. You'll need an attorney. You'll probably need to involve someone from your practice, like a manager, to deliver all this information to them. Because private equity, is funded by investors, they usually have more capital than other buyers, and they also are not as restricted as someone like a hospital when they're buying a practice. If you fall in a category of practices that private equity is interested in, you might be offered a pretty good deal. In terms of typical transaction structure with private equity, it's usually going to be also an asset sale. It could be a stock sale. It's more rare. In order for private equity to buy stock of your corporation, they'll need a friendly doctor with a corporation to acquire the practice, right? And it does happen. Transition period with private equity is usually longer. It's 1 to 5 years. The longer you're willing to stay usually could result in the higher price, because if the seller stays, that cash flow that the practice is generating is more stable. If nothing, if they have to replace with the seller, there's more risks involved, so they have to hedge their bets a bit. The value that they offer could exceed hospitals and doctor offers. As I mentioned, be careful of the creative deal structures. And one thing I wanted to mention regarding private equity that I've seen a lot is the way that the process works is they need to make you an offer. An offer is usually made through a letter of intent, and letter of intent is pretty much usually always non-binding, meaning just a piece of paper that states how the deal is going to go down. But if things can change in the end. So what they do is they might come in with a very strong offer right in the beginning and offer you a lot of like what you want for your practice right away. However, their letter of intent will usually have exclusivity clause for due diligence purposes. So they will ask you to give them like 90 to 120 days to investigate further the opportunity that that the practice represents. However, after that due diligence period, the deal can change. The terms of the deal can change. They might offer you less money. They might want you to stay for longer. It could be anything really. So if you really don't have anyone else that is interested in the practice, it may be okay to sign the LOI with exclusivity and just lock yourself in. But if you have a lot of different buyers or you're kind of early in the process, maybe get multiple offers in, or tell them to exclude exclusivity clause from the LOI. A third buyer that I want to talk to you about is FQHCs, Federally Qualified Health Centers. FQHCs are nonprofit community clinics that receive federal funding to provide comprehensive services to underserved areas and population. I stumbled upon FQHCs many years ago when I was selling a pediatric practice in San Diego. And since then, I've had a chance to work with a number of FQHCs in California and as well as in other states. And overall, I had a pretty good experience working with them. And I think they could be a really good potential buyer for some of your practices. FQHCs typically provide primary care services, dental services, and mental health services on a sliding fee scale, depending on the patient's ability to pay. They're governed by board of directors. And key thing here that we need to know for evaluation purposes, they get reimbursed differently. So they get enhanced reimbursements from Medicare and Medicaid. FQHCs have been around for a really long time, I think since like the 60s. Currently, according to Kaiser Family Foundation, there are about 172 FQHCs in the state of California with 2,300 sites. When they're acquiring practices, they're typically looking for practices with a high Medi-Cal population. And I've seen them buy family practices, pediatric practices. Although they offer other services, like I mentioned, mental health and dental, some offer OBGYN, even optometric services. I haven't really seen them buy those kind of practices yet. The goal of the FQHC when they're acquiring the practice is to expand their patient base and start offering additional services to these patients. So they might buy, let's say, a pediatric practice, and then upon the transaction completion, they'll start offering dental, mental health, and just integrating these patients into their community center. As discussed earlier, FQHCs are exempt from California practice of medicine restrictions, and they can hire physicians directly. Because of that, when you sell your practice to FQHC, like you will really sell it to the FQHC, not some third-party MSO or foundation. Because FQHCs depend on federal funding, they may need to go to HRSA for approval. They might also, they definitely have to comply with fair market standard. Like they don't always need to get an evaluation, but I've seen some small transactions, large transactions where they ended up going to a third party to get it approved. So I'm not really sure or who decides really at what point they need an appraisal. I had one center that tell me that anything under $300,000, like they're fine. Anything over that, they'll have to get an approval and get an appraisal. They might have someone appraise the practice if you're doing a transaction with them. When it comes to valuation, and as I mentioned earlier, the practice value has to be in line with fair market value standard, or they might get in trouble. What's interesting is that because the FQHCs get paid differently from a private practice, when they buy the practice, the revenue for the same services goes up substantially, right? And this sometimes leads sellers to believe that their practice is worth a lot of money, and they can value the practice based on what FQHC is going to be making after the sale. Unfortunately, you cannot do that because that would violate fair market value standard and also probably would get into trouble with the Stark Law and anti-kickback statutes. you have to value the practice as a private medical practice at your current normal reimbursement rates. I've had a few interesting engagements. In one of them, this doctor had two practices and he wanted to convert them to an FQHC. And so what he did was he created an FQHC and then he was going to gift those two practices to the FQHC and get a nice write-off for the value of those practices. And when I came out with a valuation, they were like pretty disappointing because the revenue of the practice is going to go it was going to go multiple times up because they were going to get grants and all of that. So I told them like, yeah, you can't do that, because essentially what you're doing is you're trying to get paid up front, right? Before you do before these patients become FQHC patients, you want to get paid for the profits that the FQHC is going to generate off of your patients. Yeah, you can't do that. Typical FQHC transaction structure, it's going to be an asset sale most of the time. Like they don't really care about your corporation. Transition time depends on the FQHC. It's kind of somewhere in the middle. It could be 3 to 6 months. If they don't have a provider to replace you, they might ask you to stay for longer, maybe a year, maybe 2 years. Like I had someone who was buying a pediatric practice and they didn't have a pediatrician yet. So the seller ended up staying and working for them for a couple of years. I think they still work for them actually. The good thing about working with FQHC is they usually have really nice benefits. So their pay is competitive, but they give you a lot of days off. They have health insurance, dental insurance, you name it. Also, your employees are going to get these benefits. So you might be in a small private practice offering very limited benefits. Once this sale occurs, the employees going to become employees of FQHC and they're going to get standard benefit package, which could actually help with transition of those employees to the FQHC. In terms of value, I already mentioned, it's fair market value standard. You want to be sure to match the valuation to what you're selling. So if you're, for example, selling your practice, but you're keeping your cash, accounts receivable, and you're giving it away debt-free, that's what the valuation should reflect. And finally, we'll talk about doctors, you guys. Yes, this is a common thing. People think that doctors don't buy practices anymore. They do. There are entrepreneurial doctors out there that are buying practices. In fact, most of the work that I do are with individual doctors, and most of the valuations I do are for practice sales, doctor-to-doctor practice sales, and partnerships. Why do physicians buy practices? They buy them for economic benefit. They want to make more money than they would being employed. Another important reason is autonomy. Some doctors just, for whatever reason, are not happy with how their employers run their business, run their practice, how many patients they're forcing them to see. That's what we kind of see a lot with the private equity, where they try to squeeze everything out of the physician to the max. So they choose to practice the medicine their own way. That's why they go into private practice. A special situation with physicians is that because they're investors, right? But they also most of the time owner operators. So they get the benefit of two cash flows. They're getting paid for seeing patients, but they also should get paid for their investment in the practice, meaning investment on the amount of money they paid for the practice. And this has a couple of implications. Number one, a practice might have a situation where the doctor is making less or like at or below their fair market compensation level if they're being employed. When that happens, there's not much money left for the investor part of cash flow, right? Because basically you own the practice and you work there, but you get paid as if you were an employee. So because a doctor buyer gets the benefit of the owner operator cash flow, they might still be able to pay you for some goodwill. That also improves their chances of getting a loan. If, for example, a private equity group were to look at the practice and they said, okay, this practice has total owners making in total $500,000, but it's going to cost us $600,000 to replace this physician because he's so productive, he's so amazing, etc. They're not going to be making any profit. There's going to be negative cash flow if they buy this practice, because they're going to have to make some changes in order to improve that compensation to owner's net equation. When you're selling a practice to another physician, the process is usually simpler than selling to private equity hospitals or FQHCs. Due diligence is not as extensive, and you're probably going to be dealing directly with the person that's making decisions, as opposed to dealing with a bunch of different consultants or executives, like with hospitals, private equity, or even FQHCs. Unlike the buyers that we mentioned before, who have access to capital and then can pay the entire amount up front, physicians will probably need to get a loan for the purchase price. There are good programs out there specifically designed for doctors. So if you have an MD, after your name, you have good credit, you should be able to get even 100% of financing. You might even be able to get some working capital. If the key thing is like you have to be a physician owner operator. When it comes to valuation, oftentimes what the physician is willing to pay is going to be limited by the size of the loan they're able to get. If a lender is going to tell you that they can lend you 500,000, but the seller wants $1 million, the buyer is going to have to come up with the difference up front, or the seller will have to finance that balance of the loan. If the price is so high that you can't get a loan, it does two things. Number one, reduces the amount of potential buyers you have because no one can get a loan. And it probably indicates that the price that you're asking for the practice is too high. I do want to caution you that the maximum loan amount that the bank is willing to give you is not an indication of value. It could be many, many times higher. So I've had a number of physicians who they were very credit worthy. They had, a lot of assets. And so it depends on the bank, right? I've had a physician that they got a really large loan to buy this practice, and the loan was based on these like crazy projections. It was basically like a startup, but the projections just like very aggressive. So they gave him a really large loan and they bought it. And then a year or two later, practice is not doing so good. He's looking to sell it. He can't get anywhere close to what he paid for it. So he's upside down, like in hundreds of thousands of dollars. I caution you, right? Some banks will say we'll lend up to 60% or like 80%, 90% of practice revenue. That figure that they're willing to lend, it doesn't mean that that's the value of the practice. Typical transaction structure, usually in the physician to physician transactions, it's going to be an asset sale. The seller's corporation will sell its assets probably to buyers, another physician's corporation, including goodwill. It's done this way because that limits the liability for the buyer. Otherwise, if they take ownership of your practice, if someone sues the practice down the road, they're the owners now. The only time really that stock sale happens, and a stock sale means you will sell shares in your corporation to someone else. If you hold some favorable contracts, like your reimbursement rates are really good, or the insurance contract has a closed panel and buyer can't get those contracts in any other way but buying the stock, that's the only time you would do a stock sale. Transition with physicians is usually the shortest because they are physicians that could be technically replacing you. So it could be a couple of months, 2-3 months is kind of normal. I don't really see it go over 1 year for physician to physician transactions. Value, as I mentioned, physicians make the market. They might not be able to offer you high valuations like private equity would. However, I've been seeing a lot of reverse trends. So the private equity was the hype for the last, 5-8 years now, maybe. And I'm seeing doctors not willing, they just don't want to sell to private equity out of principle. And they take some big haircuts on the values. So they're willing to accept less money, but not sell to private equity. And that's it. We covered a lot of ground in this presentation. I hope it was helpful. So if you have any questions, you can ask now. You can also contact me. I have my contact information out here. I think Liz had some questions, so I'll be happy to answer them.
I can get started with the questions that were in chat. The first one was on the private equity issue. These entities have been coming under scrutiny with state and federal lawmakers, including California. From your business practice perspective, who are the private equity entities most focused on purchasing California physician practices?
It kind of goes along the lines of what we saw in the chart. I've seen a lot of dermatology, ophthalmology, gastroenterology. I know there's some interest in like hematology, oncology, primary care. Essentially, they're looking for places where there are margins. And I think dermatology and ophthalmology kind of offers that. Also, like GI and ophthalmology, they need to do procedures in a surgery center oftentimes. And so that's another avenue where private equity can invest. They can buy a practice and have the doctor do surgeries, procedures in their ASC. That's another way for them to make money.
And the follow-up to that question is that who are the PE firms purchasing physician practices generally?
I've worked with derm management in the past. I can remember. I mean, I think there are many. Some are better than others. I mentioned the trick with, locking into a high offer. So I've seen, I forgot the name. I don't want to call anyone out, but I've seen this private, that was actually in California. It was a dermatology. They made like a ridiculous offer, like very crazy to the seller, which would be like, they offered more than they were asking, substantially more. And the idea was, again, lock you in, but then they were in the end not interested in paying everything up front. So they were going to give like part down, and then they wanted to sell it to work for them for 5 years. And the number was big, but the deal structure wasn't like, easy to really compare to all cash. You just have to kind of evaluate. You want to keep an open mind, I think, as a seller. Like your buyer might come from private equity, might come from physician group, and just evaluate it. Every practice is a little different. Buyers are different.
Good. We had another question in the chat. Can FQHCs buy medical practices in underserved communities where people are not insured?
I don't think why not. I mean, so the deals that I've seen, like they can see other patients. Like it doesn't need to be a Medi-Cal patient, right? They're not going to see just those patients. They can see a regular insurance too. Just that because of the way that they get reimbursed, they get a lot more money when they see a Medi-Cal patient than they would see like a commercial insurance patient. So because of that, they want the sort of what's perceived as underserved community kind of patient. So I think they can, but they'll probably try to convert them to be Medi-Cal, right? Or of some form.
Very good. I had another question from earlier before the presentation. Several doctors had their practices bought, but mostly paid with stock from the VC companies. That stock has gone to almost nothing. How common is this, and what can be done to prevent it other than getting all cash? Is there a way to pay less taxes on a sale, for instance, capital gains?
Yeah, super interesting. I mean, I can't give tax advice. You want to talk to your CPA, a professional. Big part of what you pay in taxes has to do with purchase price allocation. If you get paid $1 million for a practice, that $1 million gets split between types of assets, and each type of asset will have different tax bracket assigned to it. You want to maximize capital gains tax versus ordinary, but beyond the scope of my sort of expertise. In terms of equity, yes, so it's very interesting. I mentioned the deal structure could be very creative. I've seen transactions where, like, the crazy one I've seen was this doctor hired me to do an appraisal of his practice. I valued it. I forgot what it was, the amount. And then he asked me to, oh, can you compare? This is the offer that I got. And the offer, it just made it really impossible to compare what is it that you're selling to what you're getting. So he's selling $1 million practice, but what he was getting like a third cash, a third equity, third of the value in a new entity that they're going to set up where they're going to put the practice, a third in the MSO. And on top of that, they want a doctor to take out a loan and guarantee half of it on the new entity. Anyway, it was just like so bizarre. The point I guess I'm trying to make is any equity that you're getting, whether it's like MSO or whatever it is, you need to, just like anything, you need to understand what is this thing worth. Like if I'm getting $300,000 cash and they give me $200,000 worth of equity in this entity, well, how'd you guys come up with $200,000? Where is that coming from? How did you calculate it? What is the financial of this new entity look like? The issue that you will run into is that they're probably not going to share a lot of information with you. I've talked to some appraisers that work with valuing, like they work with the private equity groups. They give them different types. They do different kind of assessments for them, but even when they're trying to assess the health of private equity group, they cannot get information on how what their financials look like unless they're working with like the main partner. So the strategy, just like Liz mentioned, that I recommend is just try to get everything in cash as much as you can get in cash. So if your practice is worth $1 million, get them to pay you $1 million in cash, and then some whatever stock equity they offer to you as a bonus. Like it could be literally zero. Private equity, from what I've seen, also they like debt, so they will have an entity that will have like great revenues. They use the EBITDA, which includes interest expense, but they will underneath it all, there will be like a ton of debt. So maybe in 5 years, 10 years, when you're getting to cash in, the net equity might be negative. So you need to balance it by, I would say, just get as much cash as you can, and then the rest could be zero. Treat it as it might be zero. I wanted to mention one thing. The doctor that I was talking about, he told me that he spoke with other doctors that bought in, and they said, well, this entity is paying dividends and it's been paying dividends, so it must be good. Doesn't mean that, right? They could be taking out a loan to pay you a dividend. It doesn't mean that things are going well if they're just paying a dividend. Just be careful.
Very good. Another question. One of our RSVP attendees said, how can I sell a pediatric practice that's 50 years old?
If you have a high Medi-Cal population, FQHC could be a good option. I've seen them buy a number of pediatric practices. Other physicians, FQHCs, those are probably your options. And
the last question that I have is, what kind of legislative guardrails, if if you could think of any, or if you know of any, would help mitigate private equity firms from turning physician-run practices into corporate profit-driven businesses.
I don't want to say I don't like private equity because there are some good ones out there. Problem is, remember I said in my slide on private equity, they're looking to invest the money, manage the business, and then sell it. For the most part, they're not owners. They're not going to think like an owner very long term. They might think like an owner maybe 5 years, 10 years. I read it all the time, like different states implement different strategies to try to push back on their acquisitions of practices. MSOs, I feel like, are probably here to stay. That's what I've been kind of thinking the last few years, because a lot of physicians are tired of running the practice. Most of the restrictions that I've seen, they really cover big transactions, really big practices. They don't really limit someone who's doing like $1 million. It's going to be hard to regulate.
As I said earlier, I'll send the slides and a link to the presentation online. We did have a chat saying this is very helpful. Thank you. I want to thank you on behalf of LACMA and everybody in attendance. Thank you for presenting this, Alexey. We really appreciate it. Thank you so much.
Thank you very much, everyone.
All right.
Have a great day.
Thank you.